Hello, this is Dr. Lauterbach, and this is the Week 8 mini lecture. We'll start off with Chapter 11, followed then by Chapter 12. In this chapter, we're going to learn about assessing learning needs and health literacy. With a definition of health literacy, it's the ability of individuals to obtain, process, and understand their health information to make appropriate decisions. It's a necessary skill across the lifespan. It requires a whole lot of different kinds of abilities, including being able to recognize letters, form them into words, understand what those words mean, know how to manipulate numbers, how to calculate doses. There's a lot to it. We do know that outcomes are associated with low health literacy. People with low health literacy have less healthy choices, make less healthy choices, in general have poorer health, they experience more hospitalizations, and they have increased healthcare costs. There's a growing percent of the population in the United States that have limited English proficiency. The authors cite a statistic that in 2010, so a full 13 years ago, Spanish-speaking, low English proficiency people made up 66% of the total U.S. population. It also affects older people more than younger people, and people who have a lower total educational exposure than people who have higher educational accomplishments. So what are the current systemic approaches to improving health literacy? Continuing evolution is what the story is of understanding health literacy. We do have some research to go on. Purnell in 2015 published a study about the conclusions of that study were that respecting the healthcare beliefs and practices of culturally and linguistically diverse patients can help enhance positive health outcomes. In addition to respecting and understanding an individual's culture, we must be able to communicate effectively with each client in his or her preferred language. That doesn't necessarily mean that you have to be fluent in every language that every patient you see speaks. There are other things that you use. The most commonly used one in my experience is the translation phone. It is wonderfully helpful. I hope wherever you land in your practice that they have this service. But you can use human translators. I worked in a clinic as a student where we had a lot of Spanish-speaking patients, and they made a point of hiring support staff that were fluent in Spanish, and they had a couple certified translators, Spanish-English medical translators. So there are different ways. Also, written materials. And not that it is the most optimum thing, but if you have a smartphone, you can make it work in just about any language with just about any patient. Again, I would much prefer using a translation phone with a certified translator, but if I have run into people speaking usually Asian languages that we couldn't get a translator for, and my Apple phone worked pretty good. There are initiatives involved in the health literacy agenda, the Affordable Care Act being one, and also they referred to the National Action Plan to Improve Health Literacy, which comes from the United States Department of Health and Human Services, and it's a national action plan based on two principles. Everybody has the right to health information that helps them make informed decisions, and health services should be delivered in a way that is understandable and beneficial to health and the quality of life. These are a couple more documents that from various agencies that address health literacy. The Plain Writing Act actually isn't about health literacy. It simply says that federal agencies have got to make all of their materials available to people who speak a variety of languages, including their web pages. The Joint Commission monograph is a guide to help hospitals and other people that they certify in achieving health literacy. And then Healthy People 2020, and then again in 2030, have a goal to eliminate health disparities, achieve health equity, and attain health literacy to improve the health and well-being of all. So the role of nurses and advanced practice nurses is to enable clients to increase control over and improve their health. I don't think that's a particularly profound thing to say. But as it relates to a health promotion strategy, health literacy strategies need to be woven into all prevention efforts at all levels. Building one's health literacy should be thought of as a lifelong process, and even simple small initiatives and interventions can dramatically improve health literacy and outcomes and the associated costs. And that comes from the Institute of Medicine in 2011. Health literacy strategies health literacy strategies are at all levels of prevention. So it needs to be clear, culturally aligned, linguistically appropriate. Then there's the authors bring up this concept of the universal precautions approach. Many of you, I think, enter the profession before universal precautions. After universal precautions came in. So what that was about was we actually discriminated among, or tried to determine when we were taking care of patients whom were likely to have a bloodborne illness and who were not likely to have a bloodborne illness, and the protections that we used for ourselves were different between those two groups. And I don't remember when universal precautions really came in, but I think it had to be sometime in the 90s, maybe early 2000s. We changed that practice nationally and just said, no, universal precautions. We wear gloves for everybody. We take all the appropriate barriers, like in the operating room with shields and impervious gowns, and we just do it for everybody, because we don't know who has a bloodborne illness. So that's what this universal precautions means, if you were like, what are they talking about? So what they're saying here is we have to think about health literacy that way. We can't assume people understand us. We have to take this approach so that we always assume everybody will have difficulty understanding the health information. And that came from the Agency for Health Quality and Research, which is a government agency, in 2017. The goal being to eliminate obstacles to health promotion, the obstacles caused by low health literacy. Here's a little quiz question, but I think I just gave you the answer. Which action should the nurse take when using universal precautions approach to information? Provide health information in English? Nah, probably not. Assume that everybody understands the information? No, it's actually the opposite of that. Provide a post-test after providing information? Not anything I would generally do anyway. That's different than a teach-back. And assume everyone does not understand the information. So, the answer is, of course, D. That's what we mean by universal precautions as it relates to health literacy. Using the format of the textbook, they talk about, well, how would you search for this information? How would you write a PICO question? And what would the evidence look like? So a couple interesting things I think came up here. Print materials and management programs. Self-management programs. There's a lot of impact in chronic diseases. For clients managing chronic disease, a common aim of patient education is to improve overall adherence to medication and treatment regimens, and ultimately enhance lifestyle behaviors. Generic written patient material as a method of teaching self-care and management is ineffective. I should have put that in bold. Generic written patient education material as a method of teaching self-care and management is ineffective for many patients. Make that universal for all patients with chronic disease, because the management strategies are complex and they must be explained. So let me just kind of zero in on this. When we have pre-printed materials, even if it's in the appropriate language and at the appropriate reading level for patients, and we just kind of shoot them at them as they go out the door, we're wasting paper and we're irritating patients. That has been shown for decades to not be effective. The only way written materials really work is if you sit down, you, their provider. Possibly you could use ancillary staff, a nurse maybe working in the office, but it should be somebody that the patient thinks knows is credible, and you have a little rapport with. You sit down with them and you go through it and you get, step by step, not like a machine gun going through 2 pages a day of written material, but you sit down with them, you make eye contact. You guys know how to do this, but I'm telling you, there's research, loads of it, that goes back decades, never been proven otherwise. You sit down with them, you're their provider, you tell them what you want them to do. You can point to the written material. And here's one other thing they didn't bring up. Take out your pen and write on that piece of paper. It turns out that it doesn't even matter what you write. You write something on the piece of paper. And when you do that, the chances that the patient will not only understand, but implement what you're trying to do, that they will take that as their personal plan, that you did it just for them. And their outcome, not necessarily total health outcome, but behavioral change outcome, like doubles. It's amazing. All you have to do is write on it. So I hope you remember that. Here's some more information about guidelines for nurse communication. Always use the universal approach. Speak in plain language and start with the patient's questions, and then give what you think is essential information. There's a great deal of importance, patient knowledge and understanding, essentials of elements for patient empowerment. If patients don't know what they're supposed to do, how can they be empowered? You got to think about the family. When you're working, and it'll vary by culture, but have a sense, if you can, of what's going on in the family, who makes the decisions in the family, because families can be a great support in helping patients with their plan of care and their health promotion and illness prevention, or they can really get in the way. Study that I learned about when I was doing my master's work in the 80s, I learned about it from Marshall Becker. Somebody you may have heard about. He did health belief model. It was one of the original people working on that. They did a study of like antibiotics in kids, because that's a real good study, a good framework for testing the theories and hypotheses about patient adherence, patient compliance. So moms with kids who need antibiotics for like a sore throat or an earache. Those of you who have been around little kids who have an earache will relate to the fact that you're pretty motivated to get that earache treated, because it's not pleasant to be in their presence. And of course, you love them and you're compassionate. So anyway, that's kind of the model for the research. And then they test all different ways. They give them prescriptions, and then they track them, and they see how much of that medicine that you prescribed, this antibiotic, actually was given. That's kind of how they do it. And there's a lot of different variables, all very similar to what you've been reading about here. But is this idea of family support. In one particular study that I remember happened in New York in a Latina community, it was found that grandma, if she's present, is the expert and the power source of all health matters. It didn't matter what a healthcare professional said. If it was not in alignment with what grandma thought, then it just didn't happen. So when you're seeing patients, it's a good idea to find out what's the living situation. What's your family like, nuclear family? What's your extended family in the area? Who helps you make healthcare decisions? You'd be amazed how free people are to tell you, oh, I do whatever my auntie tells me because she's the boss when it comes to health. I mean, that might not be the exact words they use, but I hear that all the time. In the community I'm working in right now, for some reason, aunties seem to be the source of truth of all things health related. So you want to know that. The other thing here is teach back strategy. I know you already know what it is. Just so you know, there's tons of research that says that is probably the easiest, most effective way to see if you were clear. I always phrase it with patients like, I'm not giving you a test. I'm testing me, whether I was clear. So I'd like you to tell me what I just said. Or can you tell me how you would do your wound care? How are you going to take care of this when you get home? Again, I'm not testing you, I'm testing me. Because people get a little edgy and nervous, like, I don't know. And then if they don't have it right, you see, you've already set it up so that you're the person who failed. They're not the person who failed. I don't have any research for that. That's just a clinical pearl. Here we have a little question of something we just talked about. So what is the reason that you should avoid using generic written patient ed materials when teaching a patient with a chronic illness self-care strategies? I kind of distracted you with my right on it rant, but the message that the authors wanted you to get is they are what? Strategies are complex. Maybe the text size is too small. They're all printed in English, or the font is too hard to read, which seems a lot like the text size is too small. Anyway, the correct answer is A. When you're dealing with people with, say, diabetes and how to manage your diabetes, just generic patient education material as a method of teaching self-care and management is ineffective. So you give them a thing about diet. Well, you need to teach them their diet, not just about diet. Carbs are bad, or, too many carbs, or, you want to teach them even hypoglycemic events. Patients experience that differently. You would like people to become aware of when they may be getting hypoglycemic before they're in a flop sweat, I mean, you'd like them to go, when you've been hypoglycemic, kind of from their own experience, how did you feel? What was it like? Because most people have experienced that when they start on anti-diabetic meds. Feel a little lightheaded, like maybe you've had a drink, but you haven't, that kind of thing. You want to make it personal for them because it's just too complex to just think you can get by with pre-printed material. So what are the strengths and limitations of the body of evidence? Well, we got a lot of it. There's varying levels of research on ways to close the health literacy gap with evidence-based applications. And the most effective types of tools for educating low literacy patients are often visual, videos, demonstrations. Let people see it, because if they have low literacy with English language in particular, they will always be able to understand what you're showing them. So those are various things that you may want to keep in mind. So what are the recommendations for practice? The development of health literacy skills occurs over a lifetime through various health experiences and across different contexts. For clients living with chronic conditions such as heart failure, enhanced health literacy can help them adjust and develop self-management skills, and may even provide foresight of future risks and adjustment of life plans. Healthcare is often provided in a fashion that is the most convenient for the clinician, the healthcare system, or the payer. To foster the person-centered approach necessary to improve health literacy, nurses must spearhead systemic change by implementing health literacy interventions to nursing practice. Health literacy should be addressed for every patient, every time, and in every healthcare encounter to help mitigate the untoward consequences of low health literacy as well as patient and system outcomes. The American Academy of Nursing recently endorsed health literacy policies, strategies, and initiatives across 3 domains of practice. Well, it's 3 domains. One of them is practice, one of them is health systems, and the other is partnerships. And what's the feasibility of applying the evidence? Well, we know it's vital to provide patient-centered interventions. We know that the nursing actions should be universal, incorporate clients' religious, spiritual, and cultural preferences, speak in plain language, and create a culture of health literacy in practice settings. All of those things are feasible, and all of those things are clearly supported by good research. Stakeholders for evidence-based, it's the usual suspects: patient, provider, health system, communities. It's vital to fully engage patients in prevention, decision-making, and all self-management activities. Establish goals and outcome measures to monitor for strategies for health literacy and patient engagement. It's important to partner with key stakeholders in all the community sectors: schools, churches, community centers, businesses, and it's essential to use a multifaceted approach. Here, the little visual is, here we are in our glory, starting in the upper left, Victorian nurses, aka the Nightingale era, the mid-50s, and there is, 2 nurses in their 1950s get-ups, and then a more contemporary-looking nurse here at the bottom. But the point really is, it is, central to our practice. Among all the professions, it is central to our practice. And 2 is, when you're thinking interprofessional, think beyond the traditional health professions of doctors, nurses, psychotherapists, and that sort of thing. You got to think about public health professionals, because a lot of what we get in health education came out of public health and community health research. So we should be including those people. They exist in our community. They are usually eager to be involved. The authors also point out that there is a dearth of information provided in undergraduate nursing education about health promotion. Well, it isn't that we don't understand it. Let me defend myself as a nurse educator for a minute. This one sometimes our real savvy knowledge about what works in teaching in health prevention, in illness prevention and in health promotion. It's like Maslow's hierarchy. We have to cram so much information into an undergraduate curriculum to turn out nurses who are competent and safe in the public, because our work is so complex and difficult that you just have to almost take like a Maslow's hierarchy approach to it. And I'm sorry to say, health promotion gets the short shrift in the undergraduate curriculum, pretty much wherever you go. So you get stuff, but you don't get the background. They'll tell you, do this, but they never really explain why. Hopefully, in this course, you get a stronger idea that it isn't just somebody's opinion. There's a ton of research to support this information that we're talking about in this course, and that it is really important and really makes a difference in outcomes. We just don't have time to hit that in an undergraduate curriculum. So that's my defense. Anyway, let's move on to Chapter 12. This is about planning effective ways to help clients learn about health. So this is all health educators. Any of you who are health educators or educators anyway in the group will be real familiar with this information. This is just applying it to health promotion. Clients may believe that they should not ask questions and that providers are too busy for their questions, or they should just do what as they are told because providers know best. Is that a big surprise? Oh, here we have two nurses, one giving the other one a flu shot up the nose. You have to engage people, you're going to have to put some energy into it. Get them motivated. There's counseling and helping clients develop management skills. So that's kind of the three domains: education, motivation, counseling, and helping clients develop management skills. There are barriers for client participation and shared decision making, and importance of understanding client preferences can't be overemphasized. I would say that the biggest barrier to following these guidelines in their real practice for nurses and nurse practitioners is lack of time with patients, pressure on time. That's it. I think most of us believe this stuff. Most of us have a pretty good understanding, but it's time is the big pressure. What I've had to change in my thinking is that, I wouldn't walk away and say, oh, shoot, I'd have dealt with that infection, but I was just too busy. I would never do that. Or I know they were having chest pain and it sounded like it might be a problem, because it was like exertional and they were short of breath with it. But God, I was so busy that day, I just didn't have time. So I just treated their sore throat. I wouldn't do that. So I just don't, I try not to give myself that off ramp. I just do it. If I fall behind with the other patients, then I fall behind with the other patients. But I do, I try to be efficient, but I just have stopped ignoring teaching. They give an example from the precede proceed model that we learned about earlier. And it guides educational development. And if you went through that model again, you don't have to, but if you go back and look at it, you'll see that there's a clear educational path there. E-health, good to hear about this. We're going to have another chapter coming up later all about information technology. But e-health is a common term for interactive computer-based technologies that promote learning designed to foster health through social media, websites, and mobile apps. It is really an area of explosion, and I hope will really help in so many ways. We just don't have much of it yet, but the stuff that we do have, whether it's like tailored text messages, reminders, take your pills, it's time to take your pills, it's time to reschedule your appointment, or interactive stuff. We've got patient portals, we've got different things, but games, computer games, avatars, all kinds of stuff is out there, but I don't see it in practice much yet. So I think this is going to be an exciting area coming up. And then we have kind of learner-centered approaches. So they talk about the constructivist approach. That means figure out, you want to build on your clients learning what they've learned already, rather than approaching everybody like they're a blank slate. So you would certainly want to say to somebody who's been living with hypertension for years, and now they've come to you for the first time, you would like to know, what do you know about hypertension? Rather than launching into hypertension and blah, 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 the same stuff they've heard from everybody for a decade. Why don't you just start with, why don't you tell me what you know about hypertension? That's the constructivist approach. Nurses should ask clients what they know and what they're interested in learning. That would be motivational interviewing as the first step. People remember and use what is meaningful to them. These are principles of effective teaching beyond healthcare, just general principles of effective teaching. Have high expectations. If you come in with the expectation that they aren't going to learn it and you're just going through the motions, you are not going to be effective. It is not going to be an effective encounter for the patient. People pick up on that right away. Make an effective contact. Prompt feedback. Give me feedback from your patient or your group, if you're doing a community presentation or something. There needs to be cooperation among learners. We're looking for active learning. Get the person involved. If you're just speaking to them, the wah, wah, wah kind of approach, You're wasting your time and you're irritating your patient. Spend time on the task. If you want them to learn how to do something, sit there with them and watch them do it. Show them what to do. See how they do it. And respect the various ways of learning. So, 3 domains of learning. Here are the first 2. The cognitive domain. The first step for clients is remembering the information. The nursing actions are engage clients in the process. Tailor information to client capabilities and communication preferences. The second domain is psychomotor. First step, demonstrating and having clients perform the new skill. And then frequent repetition can help clients adapt their performance to environmental constraints and influences, like how things really are at home. And then the affective domain. It's the influence of attitudes, values, beliefs, and emotions on learning. Counseling involves encouraging reflection as a way to foster growth. How do you feel about it? Help clients and families clarify their values and feelings. Reflecting, modeling, and mindfulness based therapies have all been shown to be effective. The coaching approach is goal-oriented, client-centered partnership, and examples of effective coaching include things like e-health coaching for lifestyle change. Helping mothers with occupational performance while addressing family needs was a study done by Graham, Roger, and Ziviani. Encouraging increased activity among those with chronic low back pain. Encouraging increased activity among those with rheumatoid arthritis. And discussing sexual concerns are just a few of the studies that the authors cite showing that coaching is an effective tool. Here's a couple things you want to think about when you're thinking about the evidence and how to implement it. There are things called decision aids. These are ways that we organize evidence into options for the patients. They have to pick. They make decisions, allowing patients to clarify their personal values while they're doing that picking, and clear, accurate portrayal of risks and benefits in a decision aid. So if you're working with somebody trying to get them on a low-carb diet for their diabetes, you could there are things, these things are produced, you can find them, they're not hard to find, about, the picture shows a bowl of ice cream or some vegetables, as a snack. And then you talk about it. Well, how do you feel about it? Oh, well, I'm not crazy about carrots, but I do like ice cream. Yeah, okay, let's talk about that. Why don't you just eat the ice cream? Well, because I know. See, it's a decision aid, but it's engaging them in that decision making. There's another one out there for drinking, like, do you want a glass of water or do you want a beer? If you're an alcoholic, you want the glass of water because you don't want your life to be garbage. You really probably do. But at the same time, you're really attracted to the beer. So let's have that. And that's how you use decision aids. Videos are also very effective for some types of health teaching, when just print material isn't particularly effective. So let's have a question. In which way does the use of video support learning? Multiple viewings support repetition. Supports modeling as a component of learning. Can be used repeatedly for the same health problem. I suppose so. Reduces the amount of time to provide one-on-one instruction. Yeah, that's probably true, but not necessarily good, right? So the correct answer is B. Hey, we knew that. Video health education can be helpful because it shows modeling demonstrated in the video. The rest of them, they go on to explain why they don't make sense. I think you know why they don't make sense. They might be real, but they aren't preferred. The internet and mobile devices. Thank God for smartphones. If you can just get a way to use it, get the patients to give you their mobile number and agree to have you contact them, that works out pretty good. Contributing characteristics to effective online education are goal setting, interactive feedback, personalized coaching, peer support, longer duration of the intervention, and a strong theoretical framework of whatever study you did. Use of interactive games and interventions involving avatars has been demonstrated to be really effective, especially in younger age groups, but also in old adults. There's a study because I think my experience is in general, providers really underestimate the sophistication of their patients when it comes to interactive games and manipulating cell phones, smartphones. I mean, I'm not going to waste a lot of time on it. I'm just, think of this as almost in that universal precautions thing. Just assume, well, don't assume it. Don't underestimate it. That most of your patients are pretty savvy with this stuff, even when, they struggle with language, they aren't really good at complex processing of thoughts. They know how to do this. It's at least make sure they don't before you take this off the table as one of the opportunities you have with your patients. There's a bunch of literature about using mobile apps and text messages for interventions, and it's all been shown to work. Active learning, improved health literacy, memory, gait balance, physical activity, and diet in older adults are the studies that the authors used to demonstrate it. It's been used in a successful HIV education and screening program, and effective in changing nursing students' attitudes about their role in screening and intervening for drug use. So active learning is all the stuff you hate when you get into class and you have to, form a small group and discuss and do this and do that rather than sit there and just stare ahead, right? Active learning. You actually are not just a passive recipient of some stream of information. It works better for teaching anything. It works better for teaching in health promotion. Evaluating learning outcomes. Think about this with your projects that we'll be hearing about in a few weeks. You want to have an evaluation set up ahead of time. You can modify it, by the way, after you've gotten through if you have new learnings as a result of doing your projects. But you need to have some learning outcomes or some health outcomes related to it. And keep in mind that the context can affect the learning outcomes. So you want to remember to be mindful of the context of where something's going on, because what works in one setting will not necessarily work in another, and you have to be attentive to that. Authors report improved outcome of the alcohol use reduction in virtual simulations where clients choose water over alcohol. These kinds of active learning things work. Other areas where improved outcomes from virtual interventions include diet behaviors with body measurements in community-based interventions, intensive nutrition education, and continued communication among stakeholders. It's been proven that when a health promotion program is based on the assessment of need, outcomes flow naturally from resolving the need. So in other words, when you show up and you don't just bring something that you've already produced out of the can and dump it on people, when you actually go in and see what's going on here, what would you guys like to work on? What do you think maybe is a need? It works better. Voila, amazing. The authors talk about a mosque-based intervention tailored to Muslim women. If that was done, it effectively increased both intention and completion of mammography in a group with low screening rates. So they didn't just say, here's a mosque, let's go do an intervention around, mammography, the values of mammography. They went in a mosque and they looked at what was going on in health behaviors, surveyed people, interviewed people, figured out what was going on, and said, geez, these women should be getting their mammograms, but they're not. Got it? So it actually made a difference. People are not going to give you their valuable time if they don't think it's going to bring any benefit to themselves. So what are the strengths and limitations? Well, we hear this pretty much every chapter. There's a lack of theoretical framework for studies. We know that studies are more valid if they have a theoretical framework that's been tested before. That's why if you happen to be a DNP student with us, or when you get into your doctoral work in the future, you're going to find out that you're supposed to have a theoretical framework for your scholarly project, or if you go the PhD route, your dissertation. And it's because if you're going to have a better product if you use a theoretical framework that has been tested and used before, rather than you just dreaming something up. Okay? Neglect of at-risk population subgroups in study reports and selection criteria. Okay, true here. True in all kinds of medical research. We don't deal with all the at-risk population subgroups. Partly it's just a pragmatic thing, and partly it's being blind to it. And then the recommendation for clinicians to compile online resources for issues and client groups regularly seen in the practice setting. That would be good. You know, we should all keep records and we should publish. So where should we be doing more research? Inclusion of sufficient numbers of diverse subgroups. Cost effectiveness of health education materials. They kind of hit on this every week, right? We keep hearing, yeah. We need more cost effective testing in our research, and health outcomes and satisfaction, uptake of recommendations. Yeah. Risks, costs, and benefits. Here it is again. Yeah. It's a good way to research. People don't like to do it because honestly, it doesn't get published. There's a bias against that kind of research. So while these authors keep pounding on it, these are public health people that wrote this book. This is their life. And so they always see that gap, just so you know. That's why we see it week after week after week. But it's good to keep in mind that there is a big blind spot in our research, and it is around health effect or cost benefit in these public programs. And then feasibility. Required analysis of systemic and economic influences for health promotion should be done. Important central themes are to engage stakeholders early, listen carefully, summarize key thoughts and evidence, and create a plan including a timeline. You finding that out, I suppose, right about now with your projects. Identifiable outcome evaluations and cost analysis to be evaluated for sustaining the health education program. Let's go way back to Chapter 11. Here are key points from Chapter 11 where we talked about health literacy. And you've got them right here. You can upload these if you want to for your study sheets or whatever. Health literacy is the ability, is just defined here. Research has established a clear link between limited health literacy and poor health outcomes. In the U.S., low health literacy disproportionately affects minorities, individuals who do not speak English, low-income households, and the elderly. Nurses and other providers engaged in primary and secondary levels of care must provide clients with relevant, easy-to-understand health information about diagnoses, conditions, and treatments. Healthcare organizations can help improve the literacy levels and outcomes of their clients by setting goals and outcome measures for a health literacy program in their organization. Key points for Chapter 12 that we just finished. Apply the principles of effective teaching. There's a slide on that. If you don't remember, go back and look at the slide. Facilitate learning in the cognitive, psychomotor, and affective domains and effectively use counseling and coaching. That's covered in the slides. Decision aids were presented along with a discussion of the evidence for print, online, and phone formats. So that was in that whole little section that we talked about different and emerging ways to improve health education materials in particular. And active learning improves health outcomes. And there you have it.